Dear fellows, faculties from home and abroad, and the audience, good afternoon. I am Dr. Bijoy Dutta, International Affairs Secretary of BSCI and National Professor of Cardiology and ICBT and Organizing Secretary of Bangladesh Cardiac Society. Welcome you all to my presentation. Now, the next 10 minutes, I will talk on huge Thomas burden, who clean the junk best. I have nothing to disclose. My first case is a 55 years woman who is hypertensive. She presented to us with cough and shortness of breath for the last 1 week and chest pain for 1 day. Her heart rate was 112, BP was normal, but oxygen saturation was gradually falling to 84 to 80%. There was bilateral basal crepitation of her both lung fields. These were her X-rays, shows pulmonary edema and the sinus tachycardia. And this was her biochemical parameters. This shows the CRP is raised, and terminal proBNP is highly raised, and troponin also raised. So the patient was admitted into CCU with the diagnosis of acute LBF with non-ST elevated myocardial infarction, and was managing accordingly. But the next day, patient developed severe crushing chest pain. The ECG shows double wall myocardial infarction, and echo shows apical hypokinesia. Then patient was shifted directly to the cath lab, but his blood pressure was raising. Oxygen saturation was 93% with 6 liters of oxygen by nasal cannula. Angiogram was started with right radial access. Right system was normal, but the LED was totally blocked with huge thrombus burden. So unfractionated heparin and ticagrelor was administered. We first tried with daughtering of 2 millimeter balloon. We tried to establish the flow, and it was established a little bit, but there was extensive thrombus. You can see there was extensive thrombus along the entire length of the LED and the large diagonal. Then intracoronary FTP butyrate was administered. Thrombus aspiration was done, but there was no improvement in thrombus burden. Then again, we tried to establish the flow with a 2 millimeter semi-compliant balloon inflated distally, and we have given intracoronary streptokinase 2.5 lakhs unit. After 5 minutes, we also gave intracoronary GTN, and a repeat aspiration, thrombus aspiration was done, but flow was established. It shows that there was resolution of the thrombus in the proximal part, but the distal part is totally occluded still. Patient remained hypoxic, and her saturation was gradually falling down, so we intubated her. Now second wire placed the second wire in the LCX, and I planned for deployment of drug-leaking stand in the proximal LED. After intubation, BP began to decrease and pulse pressure began to narrow. Patient developed cardiac arrest at that moment. Now everything is going down. We begin to sweat. Our pulse is increasing also. CPR started at this moment. New thrombus noted in recent LED stent. This is another issue. So we have given another 2.5 lakhs unit of streptokinase intracoronary, and then subsequent resolution of the recurrent proximal thrombus. Then again, we tried to establish the flow with intracoronary epinephrine, adenosine, and intracoronary epinephrine. At this moment, you can see that at least TME 2 to 3 flow is established from the proximal to mid segment, and there is still some no reflow in the distal segment. And as the patient, and at this moment, patient was shifted to the ventilator for the 1 day and was on inotrope support for the next 2 days. Then gradually patient did, and we kept the patient on eptifibatide on maintenance dose for the next 12 hours. And then patients gradually improving, patient's condition was improving. And initially, there was echo shows no LV thrombus and LV ejection fraction was 35%. Then we weaned the patient on second day, and after 1 month, his condition was gradually improved, and his her ejection fraction was 50%. Now, my second case is the 68 years woman with chest pain and ECG shows inferior MI. Again, we started with the right atrial access. Left system is normal, but the right system shows 100% occlusion on the distal segment. And I tried to establish the flow dottering with 2 millimeter balloon. Then intracoronary GP2B3 inhibitor was tried, and frequent aspiration of thrombus with mechanical thrombosuction. Then you show still the flow was not established distally. Then again I try with intracoronary lytics, and TIMI 3/4 is established distally. Then I plan for stent implantation, and this is the final view after intracoronary lytics. So there are few case reports and meta-analysis regarding the use of intracoronary thrombolytics. If we use it with 1/5 to 1/6 dose, that is for streptokinase, 1/6 dose is 2.5 lakhs units intracoronary injection. There are few meta-analysis that administration of intracoronary streptokinase improves TIMI flow rate, myocardial blast rate, and shortening of TIMI frame count without increasing the risk of major and minor bleeding. And it decreases the MACE, 6-month MACE rate also. And we all know that there is 60 to 70% of the primary PCI patients have huge thrombus burden, and there is no refluence, slow flow is an issue. So we have to keep in mind. In these 2 cases, I managed with intracoronary thrombolytics. And in summary, intracoronary thrombolytics may reduce thrombotic burden in the infarct-related artery, which is often responsible for microvascular obstruction and no reflow during primary PCI. In these 2 selected cases, intracoronary thrombolytics played a pivotal role, as there was extensive thrombus and the presentation was early. So thank you for patient hearing.